And I very vividly remember the Basel Psychedelic Conference at the occasion of Albert Hofmann's centennial birthday. And at the very end of the conference, I remember meeting a guy who came up to me, and he was very frustrated. And he was really pissed off. And he said, I asked him what happened. He said, no, I went to talk to Rick Doblin, and I asked him what his favorite drug was. So this was after the conference. And he said, MDMA in a therapeutic context. And he thought that was such a politically correct answer. and at that point, I felt him. But now, over the years, understanding more about MDMA-assisted therapy, I actually see the point. So my opening question would be, is MDMA actually a psychedelic in the true sense of the word? This is a question to both of you.
Well, one thing that I learned when you set up a nonprofit organization is you want to have a broad mission, so you could do pretty much anything that you think is the most important. So we set up MAPS, and psychedelic, the original definition of it was mind manifesting. And that was created by Humphrey Osmond. He actually wrote a poem to Aldous Huxley to propose it. It was to fathom hell or soar angelic, just take a pinch of psychedelic. And so it means mind manifesting. We include hyperventilation, breath work is psychedelic, meditation is psychedelic, so we have a broadest view of it. So I think to answer your question, the classic psychedelics function differently than MDMA. But I think using the word psychedelic to apply to a broad, dreams are psychedelic, that they bring your mind to the surface. So I think maybe that confuses people because MDMA is different than psychedelic, but I knew that when I started the nonprofit, I wanted to have the word psychedelic in the title, just to attract people that really cared about psychedelics, but I also wanted to not be limited. So we defined it in a very broad way. Let me add one thing, though. If I were stranded on a deserted island all by myself, and if I had to have only one drug, it would be LSD.
So what would your desert island drug be?
Right now. You can prove it.
Purely theoretically, Torsten, what would your desert island drug be?
Yeah, I would generally definitely agree with what Rick said. One thing you could be skeptical about is that your cognition is kind of intact during MDMA or a moderate dose, and also your ego is intact, also your defensive system is intact somewhat. You can leave it beside, but you also can get it back. It means if somebody would ring the bell on the door, you would behave completely appropriate. He might not even register that you are under the influence of a drug. So the ego dissolution component and the cognition alteration component are different with MDMA. And so therefore I would do a little kind of separation in between the classical psychedelics and MDMA in that respect. But in general, if it comes to a certain impact a drug experience can have on the individual, I would say it could have the same kind of impact in the same direction as with the conventional psychedelics like psilocybin or LSD with MDMA.
And I would say the reason I chose LSD if I'm on a deserted island is because of what you just said, that you can negotiate with MDMA. And so that's a good thing in therapy. If you're not ready for something, you can say, I want it to come back later, or I don't want to deal with it. But there's something about LSD, you just have to surrender to it. You can't really negotiate. And so I think that's a really valuable thing sometimes, that with MDMA you can kind of steer it and you might not see what you need to see unless you're really ready to do that. But with LSD, it'll bring you to what you absolutely need to see.
So you could say that that LSD might kind of make your brain labile or more sensitive to some influences, but it doesn't have a certain, it doesn't give the experience a certain makeup or direction. But with MDMA, also from a pharmacological point of view, the effect is much less subtle on the brain. It's much stronger, and so it gives you a much more safe frame for a healing experience than with LSD. And from a clinical point of view, LSD and other classical hallucinogenic drugs are much more complex to handle in a therapeutic environment than MDMA. And I'm really happy for the traumatized patients because they can't profit as much from usual psychedelic or psycholytic therapy because of that. Because they can't steer the experience as much, and as a therapist you also can somewhat guide the experience, but in some respects you're not able to do, and so you're kind of being with the experience even if it is kind of traumatizing and stuff. And we have seen that in rare cases, but it happens, but not with MDMA.
Yeah, I guess just
it's much more benign.
To add one thing, I did work in 1984 with the first time I ever tried to work with someone with PTSD. And so we did the first session with MDMA, and it was tremendously helpful, but it was like a tour of all of the traumatic experiences of her life. But we felt that it wasn't, it didn't sort of break open or end the PTSD. So we waited a couple weeks, and then we decided to do an LSD session. And so in the middle of the LSD session, it was so terrifying and so frightening that she couldn't make any progress at all. And so we thought, well, let's do half a dose of MDMA. And that was the breakthrough. It was the MDMA made the fear go down so that things that were symbolic and like happening on another planet, happening to somebody else, then transformed into what was actually from her life and her history. So I think that even with the work with Dr. Bastians, it would be really interesting. I think that there's sometimes people just get stuck, and you just, it's too terrifying. And the MDMA transforms it.
Can you expand that point a little bit more broadly across indications? So what would the differences be, or what would the indications be that MDMA might work on and that classical psychedelics might not, or vice versa?
This is not so easy to answer, and a general kind of agreement around underground therapists is that you give the patients in these group sessions, you give them 3 times MDMA before the option to get LSD is offered. You know, usually they take it much later, but it means the benign state, altered state you experience with MDMA, it's profound, it's deep, but you can steer it much better, and it's much less dangerous because the anxiety centers are kind of out of order in a sense, and so it's a much more benign experience. And when people can have enough trust into that altered state induced by MDMA, then they might be able to steer somewhat an LSD and cope with an LSD experience much better.
Yeah, I would say couples therapy is really ideal with MDMA, but not so good with the classic psychedelics because those are more internal experiences. You also have these periods of time where you can't really talk if you've taken enough. And so I think that there's a much more personal kind of experience. I would say people with schizophrenia, we haven't really started that research with MDMA, but MDMA is very integrative. You know, Timon, you talked about the different parts. You know, so I think that one area of exploration would be MDMA for schizophrenia, but I think people would need to be on an inpatient basis. You'd have to watch them much more closely, but it could be more helpful. And I wouldn't think that like a classic psychedelic would be good for a person like that. I think depression is good for either ways. I mean, we're seeing good results so far from psilocybin for depression, ketamine for depression. I mean, ideally, I would think eventually in these psychedelic clinics, even for depression, you would go from, MDMA to ketamine to psilocybin. You'd experience different ones in a longer course of treatment.
So I would just mention again group therapy. It's much more ideal to conduct with people on MDMA. And also with the Swiss experience shows that you can use as well psilocybin, LSD and MDMA in one group together. Sometimes therapists tend to think, oh, we just use that one substance and we know when it's going on and what kind of experience will result and so on and so on. And we have a much more homogeneous group, but the empirical findings show that the more substances that are involved in respect to psychedelics and MDMA, the better the outcome will be. So it seems that these energies are kind of harmonize better if you have different substances involved. So I would say usually it's better if you have 2/3 of the people with MDMA, then the others on LSD or whatever can be better absorbed in the whole thing. And it will be an MDMA-like base so to say, a very safe base as far as I can tell.
Why would that be better, to have people on different drugs at the same
No,
time?
I shouldn't say better, but
Okay.
the experience. No, yeah, even I wouldn't say even more effective. But the group is getting a more harmonious state if you have different substances involved. It was a big debate in the underground community if they should take all people take the same drug or not. But the empirical finding, when they tried it, they found that it's better if you have different psychedelics involved. And it seems that the energies are absorbed by each substance, I mean, the whole thing together. You don't want to, I should put it that way, you don't want to have an orchestra with just one instrument, right? Is anyone who want that? I mean, 15 people playing the same instrument. I mean, if you have different instruments, it can get a better harmony. That's a definite empirical finding from that. But it has to be mentioned that the group therapy option is much better to do with MDMA involved. Definitely so.
That's interesting, because I know in the holotropic breath work that a lot of times there'll be group sessions, sometimes with hundreds and hundreds of people. And there's, every one person has their sitter too. So it's like a one-on-one, and then there's floaters that are more experienced. But I found that when I've been both either a sitter or floater or also a patient or a experiencer, that when somebody somewhere in some corner is like crying, you kind of draw energy from that, or they're letting their feelings out. So I can see how you could have different drugs in a group, and when people express their feelings or so, you can, it draws something out of you even more.
And there are also a lot of kind of similarities in between the psychedelics, even if we can also point at differences. For example, the research of Matthias Lichty, who has done research with MDMA as well as with LSD, shows, but you have to look for the measures, but they show that the feelings are kind of the same with both drugs. Pretty interesting, but it may be also a problem of the measures which they used, right? They might be too superficial or not deep-reaching enough or so to detect the differences.
Well, that raises an important point. Which is that...
That's why you're in the middle.
Yeah, really. So I would say in the 1950s and 60s, the work with LSD and psilocybin, with alcoholics, heroin addicts, cancer patients, the one consistent finding was the depth of the mystical experience was correlated with therapeutic outcome. And in the current research that's taking place with psilocybin, it's the same, that in wide number of addictions, obsessive compulsive disorder, the depth of the mystical experience is correlated with therapeutic outcomes. And so we use that same exact measure in the MDMA research. And we find that, surprisingly, people on MDMA, they don't score quite as high on the mystical experience questionnaire, but they do score pretty high. And there are about 1/3 of the people will score above 60%, which is the cutoff for having a full mystical experience on these questionnaires. But there is no correlation between the depth of the mystical experience and healing under PTSD. So I'd say that's the main distinction between what we're doing with classic psychedelics and with MDMA. And so with the classic psychedelics, the therapists are trying to help people let go into this ego dissolution state. And that's another reason why in the MDMA therapy, we're not trying to steer it anywhere, because there does seem to be a need to actually imagine and think about your trauma while your ego is intact, while you can remember what happened to you in your life as an experience, and then sort of process that so that we find that people's memory for the trauma is enhanced, but you're replacing then when they reconsolidate the memory, the episodic memory is enhanced, but you're switching out the memory of fear and panic and terror with something that's peaceful, and you're also changing the memory from something for PTSD that seems like it's always about to happen, or you're never really left it in the past. And with MDMA, you're able to process it and put it into long-term memory storage. So we haven't quite mentioned it, but MDMA increases connectivity between the amygdala and the hippocampus, and increases activity in the prefrontal cortex and decreases activity in the amygdala, so that you're able to kind of take memories that are not fully processed into long-term memory, and you're able to do that. under the influence of MDMA. So I think there's this, while the feelings and the stories are the same, similar with classic psychedelics for MDMA, that's the main distinction that we found.
Yeah, and it's an important point. I'm not quite happy to say that there's no evidence from the scientific studies in the past that the impact of the magnitude of the mystical experience is correlated with treatment success. These studies don't exist. It was always people will always tell you that, but it's not the case. The Johns Hopkins people were the first who have proven that connection, and it seems that, you know, if you are following the psychedelic paradigm, you are looking out for life-transforming, personality-transforming, mystical experience. So you tend to be fixed on that. Even if that is just 10 minutes of the whole experience, it might have a certain impact. I don't want to go against that. But what's about the other 7 hours? I mean, you are processing your personal material. You know, but that's more banal. That's not as spectacular, right? But it's also part of it. And all the old, very old therapists, if you ask them, they will tell you, yeah, we focused on that, but there is a lot of other stuff going on, which is from the more biographical psychodynamic realm. And even Bill Richards' study, which was with DPT and terminal cancer patients, and looking out especially for that thing, they didn't find it. There is not a correlation, even if it's a rumor about it. But the newer studies have proven that. But it might be also a kind of mental fixation on the mystical experience thing, you know, and all the other parts of the experience might play a role too.
So that aspect of the mystical experience and what you just mentioned about...
I guess you gotta follow the data.
But those aspects, they do make me wonder. You were talking about the synergies in group therapy, about mystical experiences. If you're really honest, because this is an important aspect of what we're trying to do, or what we're trying to talk about, is do you think that this form of therapy really will fit into the current mental health care system? And do these types of experience, do they have a place in the current way that we treat mental disorders?
Well, I think if it really works as well as we see so far, that the mental health system will accommodate it. But I think for our point of view right now, one of the biggest issues is the insurance, getting the insurance. It may not be as big an issue here in Europe, but in insurance, people tend to pay for therapy or they pay for medication. But these kind of medication, the psychotherapy combinations, and insurance doesn't pay for 2 therapists. So how are we going to get the insurance companies to pay for it? That's going to be our issue, and that's where the healthcare economics is coming in to try to show that it's still justified, even though it's got 2 therapists instead of 1. For the Veterans Administration, you know, as I mentioned, they have over 1 million veterans with PTSD, and what they've said to us, the National Center for PTSD, which is part of the Veterans Administration, they said there's no way that they could handle it internally because they're so stressed for time that their therapists see somebody, you know, 1 hour every 2 weeks or 3 weeks, or the idea of 2 therapists for 8 hours for one person. They just can't figure that out. They don't have the resources to do that. So that they will likely contract out to these psychedelic clinics and refer out and then pay these specialized people that have been trained. On the other hand, we're just getting very close to hopefully the first study inside a Veterans Administration, the Bronx VA, with the woman Rachel Yehuda, who Eric has educated about what we're doing, and then she's gotten really interested, and she's sort of the pioneer of epigenetics and the epigenetic transmission of trauma. She worked with Holocaust survivors and their children and grandchildren, and so I think that there's maybe a possibility that the VA would figure out how to do it and if it really works, but I think that's the key. If we show it works, the systems will accommodate around it.
That's an optimistic view, and I know Torsten to be more of a realist, or even maybe a bit more of a skeptic.
No, what I think about is that during the last 30 years, I've put a lot of thoughts into why is there so much resistance against these kind of treatments. There are different reasons for that, historically driven and so on. But one reason is that I found out that we have kind of three paradigmatic taboos in Western medicine, especially in respect to the physicians doing that medicine. First off, they are in fear of alteration of self-control. A lot of physicians are that way. They don't want to hear about your feelings because it might alter their self-control, and they don't want to go into drugs which alter self-control. The second thing is feelings. They don't want to get your feelings. They want to get your symptoms. They want to do the treatment, blah, 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 but they don't want to get your feelings, not really. Partially because they are themselves, in a way, disordered or schizoid or whatever. It's true for a lot of them. And the third point is touch. You know, this is virtually forbidden in our culture to use in therapeutic or especially psychotherapeutic work. And so if you put these points together, alterations of self-control, emanation of feelings, and the use of therapeutic touch, these are the three taboos. If you look at the medicine men during the last 35,000 years, they use exactly that as the essential ingredients of healing. And so I think our culture might have a problem with these kind of things. The other thing is, the more modern approach is you give the person an antidepressant if he has a PTSD or a depression. These drugs have been proven to treat not your mood. They just make you emotionally numb. That's it. And so my profession is trained to make people emotionally numb. And so how should we change the mentality of my profession to accept that they have to be more psychotherapeutic-like, you know, to accept, to handle these feelings, to be on a trip with a person for hours and accompany them and guide them and take part in their emotions. You know, I think that could be a really hard part to integrate that.
Do you see a way out of that?
Yes, it seems, for example, that the applications for the MAPS training are high. So I think there might be a younger generation, and okay, I forgot the optimistic part. But it's not just about the young. We have to be optimistic about that. But the other thing is that during the 1970s and 80s, we had the humanistic psychology movement, which was much more into experiential therapies, as they called them. So you make some experiences to make some progress, and you feel more of yourself, of your body, of your feelings, and so on. But this stuff was completely suppressed through the antidepressant drugs, as well as these cognitive behavioral orientation in psychotherapy, which is less time consuming in the education to become such a therapist, less time consuming, less money consuming. Who would do something else?
Well, you're reminding me of a quote by Max Planck, who talked about science, but it maybe could be science and medicine. What he said was that science precedes funeral by funeral.
Yeah.
That even among scientists, they're not always responsive to new evidence. And so I think this idea of the younger generation. So we had the world's largest psychedelic conference ever was in April 2017, Psychedelic Science 2017. The next one we've decided will be 2022 in April. So when you plan your next open conference, we'll try to
2 years
coordinate.
after ours.
Yeah. So, but we had Tom Insel, who was the former head of the National Institute of Mental Health for many years and was really one of our main speakers, and then also Paul Summergrad, who was the president of the American Psychiatric Association at the conference. He was president and organized a conference that Eric and I met at. And what they said that most impressed them about our conference was how many young psychiatrists and medical residents were there. And so they really see that this is there. I think there's a lot of psychiatrists that have gotten burned out from just meeting with people for 15 minutes, giving their medicines, not really having a human connection. And so I do think this younger
Don't heal anybody. Yeah, also true.
Yeah, it's interesting that you mentioned that, because a couple of us, we organized a symposium at the Dutch National Psychiatrist Association conference. And this was the first time we had a special symposium dedicated to psychedelics. So we had 90 minutes, So this was the first time we figured we'd have a small room somewhere and people might be cramped to see it. But I was shocked and a little scared to see the size of the room. So they booked the biggest auditorium for us. I think we had 250 to 300 psychiatrists or residents that were interested in hearing about psychedelics. So I do think that there's a tendency among young physicians.
The other factor is that, I don't know if you know that, but because of this insufficient efficacy of all the psychopharmacological medication, I shouldn't say all, but a lot of it, the pharmaceutical industry is out of business in respect to psychopharmacological agents. They don't develop anything anymore since nearly 10 years. They are completely out there. And that means we are, as psychiatrists, we are in a kind of dead end, somewhat, because we evaluate the older studies about the antidepressants and find that they were fraudulent, and we make the people just emotionally numb. That's not a satisfying perspective. And so therefore, because psychiatry is in a dead end somewhat, we need something else, and so the people might jump on it. Because out of that background,
I'll go into questions in a minute. There's one more topic I wanted to touch upon, and then I'd like to open it up to the crowd, so you get your chance, Dolf. So one topic I wanted to discuss is you mentioned your very deliberate strategy about working with MDMA, working with veterans. I'm wondering if you look back at this strategy, do you see any potentially unanticipated consequences of working with the military, of working towards medicalization in terms of accessibility or people who might profit from using MDMA, especially because somebody mentioned this just before we started talking. The US military in particular, but the military in general doesn't have a very good track record in terms of using or working with psychedelics with integrity. So these are many issues to address, I know, but my main question is unanticipated consequences of and negative consequences maybe also, or potential consequences of this strategy?
Well, just several days ago, there was some unintended consequences. So there was an article that was written by a military person that was about microdosing LSD and psilocybin and whether the military would be picking up this for operational efficiency. So we know that the military uses modafinil, the U.S. military, Provigil, and methamphetamines. They use these as, keep people awake, keep people focused. You know, Germans' Blitzkrieg was all about methamphetamine. And so I had nothing to do with this, but our staff posted on our social media just this article about the military possibly being interested in exploring microdosing. And we got hundreds of comments, many people criticizing us for posting this article and saying that we're pro-war and, we should be ashamed of ourselves, that we shouldn't have even posted this article and there's no science behind it. So I think one unintended consequence for at least that article was I just thought we're sharing information. I mean, when I looked at it afterwards, I didn't know it until it was all over, and somebody on our staff said, we've got all these critical comments, and people are like really mad at me and mad at others. So the main critique, not in that article, has been, are you, Torsten, okay, let's go back to Torsten. Torsten, you told me this. What if there was German concentration camp guards, and they wanted to be treated for their trauma? It was very traumatizing for them to kill all these people. And would you offer therapy for a concentration camp guard? My answer is yes. And hopefully what happens is you're not just like fixing a broken piece and then they go back and do the same thing that they've done before. Hopefully you're sensitizing them to the emotional consequences of what's going on. They're already burdened by that, and chances are under MDMA they would come to terms with that, and they might not go back and do what they were doing before. But that's the potential unintended consequence. Are we enhancing the war machine and making it so that the war crimes that people do, that they'll keep on doing them, and that we're just So I was in Israel not too long ago and ended up working with somebody who had PTSD, and it turned out that the initial part of it started out that friends of his in his unit had been killed. A terrorist had snuck in and killed a bunch of people. He discovered them in their sleeping bags. They were murdered, and he's had trauma from this. And he's been unable to function for months before, and his wife was the one that said he needed to go for therapy. And so that's what I thought we were working on. But then as the session got deeper and deeper, he started sharing that what had actually happened is after that, he and his friends had gone crazy, and then they started committing war crimes against Palestinians. That they had to, I don't know if anybody's seen the movie Waltzing with Bashir, but it's incredible about PTSD and about the Israeli move into Lebanon. So what I saw this person wrestle with was that he really wanted to make amends to other Palestinians. You know, that it didn't make him say, oh, I did that, that's fine, and now I'm it's not like going to confession, and you confess, and then you can go back and do it again over and over, and you'll be fine when you go. I mean, I don't want to speak too bad about confession, but it just seems like an easy way out for a lot of things. So I think that's the issue. But my personal belief is that it makes, by sensitizing people to the emotional consequences of what they're doing, you're going to make them less likely to do bad things. On the other hand, you know, the conversation before, if you give it to people before they go to war, are they going to not go to war? And it depends on the war. I mean, I think that sometimes, like in World War II, I mean, I don't think it would have been a good decision not to fight against the Germans. I mean, I think there was reasons to go to war, and I think when we find that a lot of the PTSD that American soldiers are having right now is because they didn't believe in the purposes of the war. And the war wasn't really for, it was for political gain by our political leaders. It wasn't a war of necessity or even a smart thing to do. So I think that there's a time where you need to defend yourselves, and so I think it depends on the war.
So, and yeah, you want to comment?
Yeah, just a very little comment. So we are so near to Den Haag, as far as I know, that we should mention that the Iraq soldiers were all criminals under international law. But that's just a marginal thing. I know an unanticipated consequence. That's what you were asking for exactly. This is that they didn't sponsor his trials, the military. You expected that they have.
Well, I had hoped that. No, they have not sponsored it at all. But the goal is eventually to help them adopt it. Yeah. But no, they were, well, that was just because of the stigma.
You were very near to it. That the second highest one said yes, but the highest one said no, or kind of that, right?
Yeah. We went all the way up to the Assistant Secretary of Defense for Health Affairs, and to the Veterans Administration. What their actual reason why the military, the Department of Defense, what they told us why they didn't want to get involved is that there's, and I'm not sure if this is the Dutch situation as well, but what we were told is that there's mostly young people in the military. The younger culture is more open to drugs. Mm-hmm. And so they were worried, and there's so many people that have PTSD in the military, that if they were to authorize a study for MDMA for PTSD, the others who felt they needed it might go out and self-medicate. Mm-hmm. And they said that would be a big problem for the military because they're trying to enforce all these drug laws and things. And so that's why they said we should start with the veterans. Mm-hmm. But the other part of it is the closer you can treat somebody to the trauma, the more likely they are to get better and the less time that they suffered. And it may indeed be that it's less expensive. You know, maybe they need only 1 or 2 sessions instead of 3 sessions. So we do want to head towards working towards people closer to the trauma, both in the military and emergency rooms. When people have come in and been raped or been in an accident, you might want to treat them shortly thereafter instead of waiting till they get PTSD. So so that's something that some of our staff has actually been wondering, what are you doing helping soldiers? They patch them up and have them go back to war. And my response, and it's kind of complicated, but to simplify it, it's in America we have civilian control of the military. And so the military, there's something noble about being willing to give up your life to protect others. And so I think the real criticism, it gets confused. You criticize the soldiers when it's a political decision that was made by other people, that why they're doing what they're doing. And so that's where we should be focusing our criticism. It's not on the soldiers, but on the politicians that send them away.
But sorry, what's our discussion some years ago when you started the veteran research, you argued that they will not go back to war. even if the PTSD is gone. What is your experience during the last years?
Well, we've only worked with veterans, so we've not actually worked. But I think that, again, it depends on the war. There are some of the veterans who've said that they had to leave the military because of PTSD, and if they would have been treated in the military, they might have stayed.
Okay.
So I don't think the being sensitized to your emotions and all makes everybody a pacifist. I don't think so. So I think some of them would continue, particularly if they believed in the cause that they were fighting for.
Okay.
All right. Yeah, I have many more questions, but I would also like to give the audience a chance to ask some questions. Yeah, right. Oh, sorry, Dolph, you had a question before. Please wait for the microphone so everybody can hear.
It seems that depression has become our national disease #1. As Torsten said, treatment by the normal psychiatrist is sort of dead end. I read 30% is non-treatable. So could you tell us something about MDMA and depression, and how close is the product-market combination?
Well, one reason that we've never studied depression. So most of the people with PTSD have depression. But we treat the PTSD and the depression goes down too. Early on, when I was trying to figure out, what patient population, the general understanding of depression was it's some biological problem, it's not related to your life, and that's why these medicines are something that you need, and you need it every day to correct this biological deficit. So I felt that we should stay away from pure depression, just because the theoretical construct would be confusing to people. How is it that we're trying to treat this biological thing with psychological, psychedelic experiences? So I think that the psilocybin has been pretty effective with depression. Ketamine is effective with depression. I think ketamine would be more effective if it were combined with therapy for depression. But and there are people that have reported MDMA being helpful for depression without them having PTSD. So I think that's something that deserves to be researched, but it's so resource intensive to try to make a drug into a medicine that we've basically had to, we did social anxiety in autistic adults and found that it worked great, but we've had to stop that research. We did life-threatening illness with people with anxious about death with MDMA. We've had to stop that research. We are starting a small study with eating disorders with MDMA, but that's because a new donor has come and said that's what he wants to support. So I think it'll be some time before we actually study MDMA in people who have depression without comorbid PTSD. But it's worth doing.
Yeah, I think so too, but I will make you aware of a methodological problem which is really serious, which is that because they try to standardize the diagnostic features worldwide, the World Health Organization, we have right now the ICD-10, International Classification of Diseases. This is a universal instrument you use in every country. The problem is that diseases are just defined not in respect to their causes, they are just defined as a certain pattern of symptoms which can have different origins, right? From a neurobiological alteration to psychoorganic features, as well as an accompanying symptom with PTSD, as well as pure depression, and then you can have different origins. Usually you have people which are in a psychological crisis in their life which develop depression, being mobbed on the workplace, etc., having divorces and so on. And you have people which are not able to make a successful life because of psychological inhibitions, etc. And so these people can definitely be treated from my personal experience and view, and we have treated them and they are not staying on the antidepressants anymore. They got a lot better, but we have to look out that we can't say when the psychologist in my clinic, psychotherapists show up and say, oh, he has a depression. Then I said, okay, I'm coming to the doctor and saying, I'm having pain. What does that mean? It doesn't mean anything. So where is the pain? When did it develop? What bettered it? Is it there at night? What is the character of the pain? And so on. Then you find out about the illness and the cause. But it's not a cause to have depression. It's like, I'm having pain. Yeah, what does it say? It doesn't say anything. And the problem, what I want to make you aware of, is because we are just defining the illness as a pattern of symptoms, we are not allowed to differentiate in studies, in clinical studies. This is a depression stemming from neurosis. This is one caused by life crisis and crude life circumstances. And this one is mainly biologically caused. We are not allowed to do that decision, this differentiation. So we have to include a kind of everybody. And that makes these studies so complicated. It's better if you have a PTSD with depression or anxiety, it doesn't matter. You can measure the symptoms, but you can't really do a study on depressive patients, as we have found out. It's really not easy to do.
Well, I would
but
just...
I think that MDMA in the context of an appropriate psychotherapeutic setting can be very helpful with depression, in fact, with most of them, 80%.
That there's a little bit, I'd say it's more nuanced, so that I described earlier how the group that did the work with psilocybin for anxiety and depression in cancer patients, when they went to the FDA, they said, we want you to work with anxiety and depression in general, not just from the cancer patients. However, if you happen to have a hypothesis that this group of depressed patients will respond better to this kind of therapy, you can design a protocol just for that group. So it's not that you have to include people from
this is
depression.
what we were in fact told by the Swiss authorities.
Yeah, well, the FDA wouldn't be that way. So that you can they call it subject enhancement. You can try to pick your top responders, and you can target the study for them. You just have to be aware that when you get it approved, you can't overgeneralize. But if you did have a specific hypothesis, this kind of people would be best, you could do a study with them. One of the things that
the problem is, how do you define that? On an based on international standards.
Yeah, I'll just say what supports you, though. One of the good things we discovered in our phase 2 studies is that the cause of PTSD doesn't really matter for the treatment. So you can have PTSD from war, complex PTSD from child abuse from a long period of time, a single accident in a car. You can have, once people develop PTSD, the treatment is more or less the same regardless of the cause. So the FDA and both EMA have permitted us to enroll people with PTSD from any cause.
Yeah, very good. So, and that also gives you an idea that MDMA does not mainly work by reprocessing trauma. Might be more work as a trust booster or something like that. And then it doesn't depend on the condition or the origination of the disease as much, however.
Yeah, just before we continue, I wanted to make you aware that we've passed 9 o'clock. With your permission, I would like to go on a little longer. Also, I wanted to make you mindful of the fact that when you pose a question, any answer will take between 5 to 10 minutes. We don't have that much more time, so make your questions count.
Okay, well, we can be quicker.
I doubt it. Yes, in front.
Yeah.
I don't believe you anymore.
Thank you.
Oh, sorry, somebody else has a question already.
Yeah, I've already got the...
Okay, go for it.
Sorry. Yeah, thank you for the conversation. And my question is directed to Rick. And I was wondering how optimistic you are to have a MAPS Asia, or and because I come from China and I find it so very hard to talk about it openly at all. And so I would like to ask, like, just to have a imagination, like if there will be some sites in China, what would you think of as a strategy politically? And would you have different arguments? Would you have different patients groups? And or would you
good question.
Let's do it underground. Yeah.
Okay.
Point is taken.
Well, I'm happy to say that we already are working in China. So what happened is there's a fellow named Bo Shao, S-H-A-O, and he has what's called the Evolve Foundation. And he said that, this is politically delicate, but he's basically said that his parents, when we had the psychedelic revolution in America in the 60s, there was the Cultural Revolution. And that his parents and their whole generation is traumatized in China from that. And so he wanted to help, and so he made a big fortune, hundreds of millions of dollars in China, in the internet, and then he moved to San Francisco. And so he wants to help bring MDMA to China. So we've had several meetings, 2 different times. One was Amy Emerson, who's our refugee from Big Pharma from Novartis. She went and met with Chinese psychiatrists, and then the principal investigator from our Israeli study was the former chief psychiatrist of the Israeli Defense Forces, and then he was president of the Israeli Psychiatric Association. So in October, he and I went to China, and we had actually 2 meetings with Chinese psychiatrists from military and civilian, and they don't have the whole history of ecstasy there, so it's a little bit easier for them. We had to stay away from talking about Cultural Revolution and anything like that. We had 2 female psychiatrists came to the training that was in the Netherlands, and now they're talking about sending 12 more to the next training, probably in October, that we're going to have in the U.S. So these are high-level, wealthy Chinese who have these connections with the military and with the civilian psychiatric associations. And so far the meetings went really, really well. Talking about unintended consequences, though, right before I went to China, I spoke at the Human Rights Foundation, had a meeting at they call it the Oslo Freedom Forum at the Kennedy Center. And there was a young Chinese, and he wasn't that young anymore. He had been run over by a tank in Tiananmen Square. So you can't talk about Tiananmen Square in China either. So when I was at the Kennedy School was when Tiananmen Square happened. And I actually organized a whole protest all over the world on the 1-year anniversary of Tiananmen Square. And our protest was about an international day of fasting. So we didn't commemorate all the murders, we commemorated their fast. And we had protests all over the world. And so for me, it's been a particular concern about unintended consequences when you go into such an authoritarian government where it's, everybody is facial recognition, and, are we giving tools that can, in some hands, be healing, but in other hands could be tools of oppression? And so I'm not so sure that they could be. So it's a difficult. I'd be very curious afterwards to talk to you about that. But it seems like from your question, you think it would be a good thing to bring MDMA therapy to China. And I think so too. And so the next step for us is to train these 12 therapists and then see what that happens. But we did have, I'm sorry, this is taking a little bit longer.
I'm not surprised.
But we had, so this is where there's cultural differences. Yeah, so, in the 2 Chinese women psychiatrists, they're watching the videotapes, and one of the videotapes was about we videotaped the therapy MDMA sessions, but also the non-drug sessions. And so this was a situation, this woman who had been sexually abused by her stepfather, and eventually her mother divorced him, and he lived in some other town not that far away, but she never saw him anymore. And so the debate was, and what was videotaped, what was shown was a discussion. She wanted to bring her husband in so that he would know what happened to her. She'd never really shared before what happened to her. And so she had to get her husband and the therapist to make all sorts of agreements that the husband would not take any action on whatever he learned. She was worried that he would go kill her stepfather or beat him up or hurt him. And she wanted him to know what was going on, but she didn't want him to take any action. So that was, we saw how that was negotiated. So the Chinese psychiatrist said that they were perplexed by that because they said in China, if a woman would be admitting that she was sexually abused, her husband would be more likely to leave her than to go attack the person that did it. So there's cultural sensitivities that we have to be aware of. But my hope is that we will bring MDMA to China. And I just think that when populations are traumatized and they act on those, they can be motivated by fears and anxiety. So the hope is that if there is more treatment for trauma in China, that it'll have a positive effect in the culture, as well as with the individuals. But that's a potential unintended consequence. You don't know.
Yeah, one thing I wondered, and I please don't go into this because I think this will lead to another half-hour discussion. But the MDMA-assisted psychotherapy training that's been developed has been developed in the US and in Europe. So would this work in the same way in Chinese psychiatry or in Ugandan psychiatry and their medicine systems?
Well, okay, this will be super short. So we're interested not so much in Uganda, but in Rwanda. So I was just in South Africa. There's the genocide in Rwanda. So, and we've met with Partners in Health, The president of Rwanda was at this conference I was at. He said he's sympathetic to MDMA and psilocybin being introduced in Rwanda. The Partners in Health people, we met with them in Boston, and they said there's only one problem of bringing MDMA-assisted psychotherapy to Rwanda, which is there's no psychotherapists. So, yeah, I think we'd do something like group therapy or peer support or something, but yeah, I think it would be very different according to which culture you're trying to work in.
All right. Yes, please. Right in front. Well, I gave her the
Thank you.
floor.
So I work with people who suffer from anxiety and panic attacks, derealization, depersonalization, and those symptoms begin after MDMA use, usually after a high dose or a bad trip, specifically that. So I was wondering, could MDMA help them get over this?
Definitely, 100%. So I think that the depersonalization, derealization that happens is the MDMA brings stuff up that's traumatic. But if they're in a situation where they try to suppress that rather than to process it, then they end up being worse off for a long time. And so we have actually worked with people who've had, so the woman that I mentioned that I worked with this MDMA and then the MDMA-LSD combination, she took MDMA with her boyfriend, and her trauma came up, and she wasn't able to handle it, and she checked herself into a mental institution, and they let her out with the same drugs, and she was in despair and even more suicidal than before. But in a therapeutic setting, the MDMA helped her to process it. We've also worked with people that have had really difficult, bad, and the difference between difficult and bad is difficult, it's hard, but bad is where you repress it and you resist it. So we've worked with people that have bad LSD experiences. Decades later, MDMA helps them reprocess it. So I would say to your patients, yes, it could be helpful.
Yeah. Okay.
So three more questions. Did somebody not already have the microphone? No? No.
Thank you for the really interesting talk. I was wondering how this would work with people who have antisocial personality disorder, like Ted Bundy or stuff like that, because it's really hyped right now. So,
Well, people have suggested that Trump should, do MDMA. But I think that the same point that Torsten was making, that we were making, that you can avoid or negotiate. People have to be willing to go there. So, I think if actually somebody were to dose Trump with MDMA, it's unlikely that it would turn out well. But I think if somebody who is antisocial has this part where they want to get better, you could maybe try to build on that. But it's about people are healing themselves. That's where I thought it was so great. And they have to be willing, and the drug wouldn't automatically help them unless they're willing.
I completely agree. And if a person is already in psychotherapy and willing to do work on himself and on the circumstances surrounding him, then it might be a catalyst to help that process in any direction, but it has to be guided, and it also is important that we not think about MDMA as a magic bullet. You still have to change your life in a certain direction if you have certain insights or being freed from anxieties or traumatic experiences. You also have to heal your life still, because sometimes it has gone in the wrong direction. You were not able to establish a good love relationship, etc., etc. So you have to, how should I say, it doesn't help you avoid the serious little work on the ego, as Freud has called it.
thank you.
So at the beginning of this panel, Rick, you mentioned that like in underground psychedelic psychotherapy, or maybe even some of the more above ground stuff in Switzerland, there was efficacy for OCD, and like I've only heard anecdotal reports of this, and not very many of them. But then again, I don't really have much of a connection, unfortunately, to the underground psychedelic psychotherapy community. So I was wondering if you could tell a little more about the efficacy for OCD.
Well, the only study that we ever did was with psilocybin for OCD. So MDMA has never really been tested. I have worked with people that have had hair pulling, and so it took multiple sessions over multiple years. But eventually, the anxiety that is controlled by these repetitive behaviors, you can help people deal with this underlying anxiety over time, and then they can control those behaviors.
Yeah, the head of my department might be interested in hearing about this.
Might I give a little short answer? So I have seen people with severe OCD symptoms under such a kind of therapy a few times, and what we experienced is that during the acute effects of the MDMA and even part of the subacute phase, the people are completely free from their symptoms, completely free under the acute effects. Sometimes they have this kind of retrospective defense. They tell you afterwards, after the session is completed and the OCD symptoms are there again, then they say, I didn't experience anything else during the state. Sometimes I was even going for them and telling them during the acute state, are you feeling your OCD thing with your hands showering and stuff like that? No, nothing, zero. And I said, please remind yourself when I ask you later on, yeah, but the effect in the long run wasn't as good. So it was kind of over, and it might have been 2 days a little easier, but then the symptoms were back. So the mechanistic efficacy is not as good. It might be different if it's embedded in a psychotherapeutic process. But
So final 2 questions, and then we'll wrap up.
Yeah. So,
Final 1 question.
so I was wondering, because now, what do you think the effect is of all the young people and MDMA becoming more popular? What effect that will have on like later use of psychotherapy later in life if they've already used it multiple times when they were younger?
Well, I would hope that they would need psychotherapy less when they're older, because a lot of people do get therapeutic benefits even from taking it at raves and doing that if they're prepared for those experiences. I think the other part of the question is that over time the effects of MDMA diminish for most people, and sometimes it takes quite a few sessions, but that would be the concern if somebody's and that's the if there is any evidence for brain changes from MDMA, I'd say that's it. That there does seem to be this diminishing effect over time. And you don't see that with LSD or ayahuasca or marijuana. I mean, you can get a tolerance to these drugs, but then you stop them for a while and then you try them again and it seems like the first time. But it's not quite like that with MDMA. So that would be the concern. Maybe they have used up whatever is happening in their brains, and then later on when they need it more, it's not available. Or the idea is maybe they've learned how to process their feelings, difficult as well as beautiful, loving feelings, and then they need therapy less. But there's, at least in my experience, there's not a cross tolerance between MDMA and MDA, which is more psychedelic. So I think even if they have done a lot of MDMA when they were young, then they need therapy. Well, maybe you could just, when they're older, you could switch to MDA.
So there are two things to say about it. One is that if you really look at the numbers of some studies, you will find that 2 very significant and seriously taken studies which have a longitudinal methodology means they look at the people at the baseline point, then a year later, 2 years later, 3 years later, you'll find that the MDMA users got better in a lot of psychopathological measures, even with just recreational use. I can't explain these results, but the 2 significant studies have shown that. They don't mention that in their abstract or anywhere, but you can see the numbers, it's no question. That's one thing. The other thing is that I personally was always wondering why no person was showing up. I had early on a website and stuff, having an impressive experience with MDMA and want to speak with a person competent in that field. Nobody ever showed up from the recreational scene. My personal explanation is that we have 2 different modes of taking MDMA. I call the one way, I call the extroverted mode, where you are outside, your eyes open, in contact with other people, sensory bombardment, that's completely a different deal than the introverted use, as I call it, where the people tend to go inside and be very reflective on themselves and feeling themselves very presently and so on. So I think if I would have been an extroverted user in the past, let's say a few years ago, then I get a trauma and get the therapy, it's a completely different deal. And to give you just a contrast about it, there was a big film about the rave party scene in Germany, and at the end, the major DJ who was shown during the film a few times was asked, "Would you do you recommend something to the public which is hearing you right now? Is there any tip you can give them?" And he said, "Okay, take the MDMA at home on your bed." Close your eyes, hear soft music. That's what he said. You know, because all the people didn't experience the MDMA experience in the sense what we are talking about, touching your inner core, etc., etc. They just occasionally are in that state, but it's not their intention.
Yeah.
Okay, so
I'll just say that we had several people.
One sentence.
We had people in our study that had taken MDMA recreationally, and they said therapeutically it was completely different.
Okay. On that note, that was actually one sentence. Congratulations. I'm impressed. So on that note, I would like to wrap up. It's 9:25. We have to be out of the building by 10, so we have time for maybe one drink. Afterwards, I think Eric would like to round it up, and I would just like to point out that for everybody who's interested in this subject, we're in the process of organizing our next conference, which will take place in almost a year from now, 24th to the 26th of April. And on that promotional note, I'll hand the microphone to Eric and thank our guests very, very, very much. You want to give him the word again?
All right, maybe this will be 2 or 3 sentences. The last word is just that in your presentation, you talked about how in the early days that MDMA was used in the gay community to help them come out. And so I think as we think about mainstreaming psychedelics, what we really need is a similar process of people that have had beneficial experiences with psychedelics, think they have value, but have been too scared to talk about it because of the drug war and other reasons. We need more and more people to come out and share with their families and with other people that they know about their view of psychedelics. So that's my sort of call to action of all of you, I think, is to help educate others if you've had these beneficial experiences to share them and feel that that's actually the crucial next step in this public education process, just the way it worked with, the coming out in the gay rights community. Torsten.
Okay, so I will be shorter, I hope. One thing is, I want to thank you because you're a very serious audience. You're very attentive, and I am also full of hope. You enriched me with some optimism. A lot of serious people are interested in that thing. And the other thing is, if we are right now using medications which suppress symptoms and emotions, we change to the medications which escalate emotions and make people and their souls more visible, manifesting if you want, it may also enrich you taking part in these processes. It's really a fascinating endeavor.
On that note, I'll just take the very, very last word. It's about 9:30. We were told, or so we planned to wrap this up at 9. I'm looking at you, and I hope that I'm echoing also your thoughts that this has been a delightful afternoon, evening, where we have been treated with a wealth of presentations. Gemma, thank you so much for giving that background where we came from that we needed to have. Tijmen, thank you for that beautiful clinical vignette that you shared with us. And here too, guys, moderated by Joost, who have this warmth and the gentleness and the wisdom and the passion and the devotion to really shape the future. That was what was in the title. So there's more to come. There's much more to come. So if you wanted to stick out here for a few minutes or half an hour or so, be invited to do so. And please join me in giving these guys a big hand and a happy journey home.